Mark Latina. I'm a physician, ophthalmologist, and glaucoma specialist, associate clinical professor of ophthalmology at Tufts University School of Medicine. I'm in private practice in the Boston area, and I'm the inventor of selective laser trabeculoplasty. So a few treatment pearls for SLT. I think when we started the initial FDA trials, the protocol was to produce microbubbles or cavitation bubbles or champagne bubbles, as we call them, in the trabecular meshwork, indicating that most physicians like to see a reaction in the trabecular meshwork and then actually reduce the power by 0.1 millijoules. So that you don't always need to see microbubbles. I think that's a pearl that I'd like to make sure everybody understands. The laser is actually very effective and very efficient, and even though you're not seeing microbubbles does not mean it's not working. You're actually in the range of treatment. If you see microbubbles and then reduce the power and don't see microbubbles, you're still in the range of treatment. So in patients with varied degrees of trabecular pigmentation, I do adjust the energy settings up or down depending on the degree of pigmentation. For those patients with moderate pigmentation of the TM, I usually start at about 0.6, 0.7 millijoules and treat if I see a few bubbles throughout the meshwork. That's fine. I do not like to see large cavitation bubbles, so I reduce the energy levels. If it's a very light TM, then I'll start at, say, 0.8 or 0.9 millijoules, and usually don't go much more above 1.1 millijoule. So you don't even need, again, to see microbubbles even at higher energies and with lighter trabecular meshworks. In those patients with more pigmented trabecular meshworks, I like to reduce the energy more significantly, 0.5, 0.6 millijoules. Also, I usually recommend treating at least 75 to 100 spots. If the trabecular meshwork is more pigmented, I tend to treat a little bit less aggressively, using about 75 spots. Third, patients with pigmentary glaucoma. These can be more difficult to manage postoperatively. They're very pigmented, and the caution is that if you overtreat these patients, this can result in a sustained IOP elevation, requiring potentially trabeculectomy. So we like to essentially undertreat these patients. You should not see cavitation bubbles in these patients, so you should be treating at 0.4, 0.5 millijoules and actually not see cavitation bubbles, and also treat only using 50 to 60 spots, so treating 180 degrees of the trabecular meshwork. In this way, I think you can always go back and retreat these patients, but your likelihood of getting significant pressure spikes is significantly reduced. So I think that those are sort of major pearls I can give you.